Hello, everyone, and welcome to the March 2021 Pre-Hospital Care Research Forum Education Research Journal Club podcast. We're live streaming on Facebook today, so you get to see our crazy backgrounds too. We're glad you joined us. Remember, the Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. Now, the PCRF partners with the National Association of EMS Educators to promote research literacy and to advance the science of EMS educational research. So here with the PCRF Journal Club, we take a closer look at some of the latest research happening in medical education. I'm Megan Corey. I'm here with David Page and Dr. Bill Toon. And thanks to Katie O'Connor for streaming us live on Facebook. And we have also one of the authors here and somebody who's really been a new panelist now on the PCRF Journal Club. There's Dave. The study we're going to be reviewing today is the prevalence of implicit bias among EMS workers. This is a cross-sectional study, and we'll talk about what that means. We also happen to have, like I said, the study author, Alex Trembley. Hi, Alex. He's here with us today to help us understand the research and the outcomes. And Alex has joined us in the past as a panelist on this podcast, so it's great to have our young researchers here. As we call them, young researchers. But first, I do want to remind everyone, and if I can advance my slide, there we go. I want to remind everyone that we do have that the upcoming call for abstracts. You still have a lot of time. Each year, remember, the call for abstracts highlights the Pre-Hospital Care Research Forum activities. Abstracts are usually received from all over, EMS providers, clinicians, educators like you, and students from all over the nation and abroad. And a peer-reviewed process will determine which authors are invited to present their study, either at a national conference and sometimes an international conference. The call for abstracts, and this is all of the abstracts, no matter what type, education, clinical, operations, systems, all types of abstracts. The deadline is the same. It is due June 30th of 2021, so you have a couple months to crunch those numbers and think of some good research questions and put that together and add to the body of literature, add to our practice. So June 30th, 2021, you can submit your abstracts online. Now, for more information, you'll want to go to, or actually email, pcrf@mednet.ucla.edu. And again, that's right up on the screen, pcrf@mednet.ucla.edu. So thank you all for joining us today. We're going to begin, and we want to remind everybody who's out there, if you do have questions as we go on, you can just type those into the chat screen. We can bring those comments, questions in as we go, and we'll bring those in the conversation. Some of us will be keeping an eye on those comments and questions. And we're going to transfer over to Alex's slides while we talk a little bit about this. So, because Alex is going to present his research directly. We have talked about, and Dave, you and I have talked quite a bit, and Bill, about the social determinants of health outcomes and how our patients in EMS might be affected by a variety of different things in terms of how they relate to the social determinants. We've talked about inequities in outcomes, but we haven't really, and we've mentioned, but haven't really talked about or looked at research on implicit bias. We looked a little bit at some really great research by Cynthia Ferranda, if you remember, on cultural humility in simulation. So that was a really great one. So if you want to go back to some of our archives too and watch some of those are actually on YouTube as well. But implicit bias, we've mentioned this a couple of times. We haven't looked at any studies in this area. And implicit bias defined as unconscious and involuntary attitudes which lie below the surface of consciousness but can influence affect, behavior, and cognitive processes. And that's a quote from the paper. So without further ado, we got our slides up, I think. Can everybody see those? We see those okay? Great. So Alex, welcome. Thanks for coming. And if you could introduce yourself and tell us how you came to doing this research.
Yeah, absolutely. Can you guys all hear me all right? This new headset thing.
Gotcha.
Okay. I'm Alex Trembley. I'm the one whose mouth is moving on the screen. I'm a paramedic here in the Twin Cities area of Minneapolis and St. Paul, Minnesota. I ended up a paramedic completely and totally by accident, and Dave Page was my faculty advisor during that time. I graduated in 2010. And since then, I've worked as a paramedic, a critical care paramedic, a field training officer, and now I serve as the supervisor of quality and education at North Memorial Health Ambulance in Minneapolis. We're one of the largest nonprofit ambulance services in the Midwest, and my main focus is really on public policy and how laws and regulations affect the way that EMS works in the state of Minnesota. I am, like I said, I very accidentally backed into EMS. I thought I was signing up for an English class, and I signed up for an EMT class. So I decided that maybe now in more of a Monday to Friday setting that getting some more education would be good. So this research that we're going to present is a culmination of 6 years in the University of Wisconsin system. First in quantitative analytics for undergraduate. If anybody would like to talk about getting a degree in quantitative analytics, I'd happily link up with you, but I imagine the line will be very short. And then I have a master's in public administration and public policy from the University of Wisconsin Oshkosh, and this paper was the culmination of that. So that's me in a nutshell.
Great, thanks. And if I'm going to have you just begin to present on your research, and again, if you're out there and you're having questions as we go, we can pull it in. We might sort of interrupt for a second and ask you a few questions about research itself, because we like to teach research as well as discuss the implications of your study. So I'm going to turn it over to you and let you present your research first.
Okay. All right, just move down to here. So Megan already kind of talked about what implicit bias is, but I'll talk just a little bit more about it to help you understand why we think it's kind of this pervasive thing that changes the way that we view the world and how it has come to affect us all. I'll talk about the study that I performed. I know it says our, but I've learned now that in medical research, anybody that works on the paper gets a credit, and in sociological research, it's just the person that wrote it. So I have nobody to blame but myself. And then I'd like to talk about what it means to be an EMS leader and what an EMS culture looks like with good implicit bias training and research. So that's me. I already introduced myself, but I like that picture. And then I kind of thought about what is it that made me want to do this research, because I'm lucky, I'm a cis white guy from the Midwest, and I've had just about every opportunity afforded to me, from originally being a welfare kid now to living comfortably in my hometown and being married. My wife is a paramedic as well. She's on right now, so I can only say nice things about her. And I noticed that over time that I didn't have any trouble walking into organizations and looking around at problems and saying, "Hey, boy, this isn't right. We should fix that." And nobody really bat an eye. Nobody really complained. But when my wife Lauren tried, she had a much higher hurdle to overcome, and she's a brilliant woman and shouldn't have any of those problems. And then we thought about Brittany Baker, who was a paramedic classmate of my wife, and worked with me part-time at a local ambulance service. And she never really found her sticking place until she eventually joined the St. Paul Fire Department in the last couple of years. And it seemed so strange to me. Everywhere I went, I had a sticking place. Everything that I did was very was easy. It felt easy, and that certainly couldn't be something that I did, right? It had to be some of these benefits. And so when Brittany Baker, a paramedic and firefighter, got hired by the St. Paul Fire Department, she was just the second woman of color ever to be hired by the St. Paul Fire Department, and in the low 20s in terms of overall people of color in the St. Paul Fire Department, and the low 20s for women as well. And that seems crazy, right? You think, oh man, that's a long time. But when you really think about it, it's only been since 1960. right? 1960, especially the mid 60s, is where those barriers started to break, and it's really where EMS started to develop those footholds. But in my mind, that's still too long. It's still too long that she's just the second woman of color in St. Paul, in this community that I had always kind of prided myself on being super woke and like really well aware and socially aware, because I live here and I like it and I believe in it. And then I had some great academic faculty support along the way. All of these folks were my faculty advisors, including Peter O'Leary, who's the fire chief and EMS chief for the city of Fond du Lac, Wisconsin, and then 3 academic faculty members that really encouraged us to think differently, and something that really changed me, I would say. So Megan already talked about Ivy Manaya's view of what implicit bias is, but I think it's important to know that it's really only been described in the literature continuously since 1998 by a group of 4 researchers that are all now at Harvard. One of the researchers did start at the University of Wisconsin, my alma mater, and ultimately made it to Harvard. So, like I say, he learned everything he needed to know in Wisconsin and then moved to the East Coast. But it's controversial, right? And it's controversial because we all believe that the problem is not us and the problem is the society around us, and that we all believe in the same things. It's this thing called the social identity theory, right? That all of us consume the same media and we all believe in ourselves and believe in each other's, but only if we align socially with those people. So an example would be like the television show The Power Rangers. My favorite television show, even now as an adult, which probably tells you more about me than it needs to, is this hailed as being one of the most diverse children's shows ever. And that's great, except the African American character was the Black Power Ranger and the Asian American character was the Yellow Power Ranger. So we think about all of these things as being really awake and socially aware, but in actuality, it helps to push these stereotypes that we probably should not prescribe to. And it affects us differently. It affects us all in different ways, in terms of the life we lead and the work that we do, is this idea of biases, and we all have them. So for instance, bad drivers. So everybody is familiar with some stretch of road in their neighborhood or in their metropolitan or exurban area that is full of bad drivers, right? The Highway 52 bridge coming out of South Metro into downtown St. Paul. Everybody waits to the last second to cut over. And when you think about bad drivers, things will pop into your head naturally. Maybe it's big trucks, maybe it's a certain race or ethnicity, maybe it's a certain gender. And that's a bias. It's a bias that your brain created based on its previous experiences, including what we take in socially. Okay. The other one is locking your car doors in certain neighborhoods. When I was a kid, we used to go into Minneapolis because my mom liked to shop in Minneapolis. But whenever we crossed the 494 border, which kind of separates the suburbs from the urban core of the Twin Cities, my mom would lock the car doors. And I thought, oh, that's just something that you do in large areas. And it's because she had formed this opinion of the urban core of Minneapolis, which is a very quiet area of the world. She had formed this idea in her head that it was more dangerous, probably because it was more diverse. And looking back now and looking at those opportunities in the past, those are the things that shape our opinions. And those are the things that may change the way that we take care of patients, and frankly do take care of the way that we take care of patients. So and then the workforce, okay? So the workforce of EMS workers in the United States is shockingly homogenous. This says fire departments. Fire departments are we have fire departments are where we have the best research because they have a national reporting database. We're not really getting there with EMS quite yet. But you'll notice here that the modern American fire department is 96% male and 82% white. And you think, well, you know, it's hard work, it's tough work, it's this great American tradition, and you always, you think of TV shows like Rescue Me and the like, where what they all talk about is like the Irish firefighter. Well, if that were really the case, then other branches of the public service in the United States would be the same. And the military, which for the longest time until the last 10 years only allowed men to be in combat roles, is only 85% male and 60% white. The police department, same thing, very similar thing, only 88% male and 73% white. And when we think about where we're trying to address social justice in the law enforcement system, in the public safety system, and we talk about police departments not being representative of the communities they serve, and how people commute in to be a police officer in urban areas instead of representing the areas that they're from, if that's true of the police department, then it's very, very true of the EMS service in the United States. And it makes us start to wonder why. And so as I did research, as I decided that this was the thing that I looked around the world and said, hey, maybe this is my chance to carve out, I looked for EMS and fire and police research on implicit bias, and I found this terrific article title, okay? And it's from a trade magazine. It's not from a current trade magazine. It's long since out of print, but and it said this: how the fire service culture suppresses prejudice and implicit bias. I'm in, right? I want to know that I'm a good person just like everybody else. And this was the hypothesis by the sociologist, PhD sociologist who wrote it. He said, just like members of other groups, some firefighters harbor prejudice and implicit biases towards various social groups. However, when the alarm sounds, these same firefighters don their gear and provide equitable care to everyone. I was like, yeah, that's very true. That's very like white knight coming in on the horse to save the day. And that's what I wanted as an EMS provider. That's who I wanted to be. But then when you think about the measures, when you think about the measures of success of EMS, um, uh, there's endless research on health outcome disparities. African American men are half as likely to recover from a spinal cord injury as white men, unless their neurosurgeon also happens to be African American. A study at the University of Virginia, a medical school, found that a plurality of medical students, residents, and physicians still believed that African American people could not feel pain. And they went and checked, and they looked at all of these medical books and all of these pieces of research to see where it came from. And it's not written anywhere. It's a holdover from the antebellum South. It's a holdover from the pre-war southern United States, where a way that they justified the trading of humans was to say, don't worry, they can't feel pain or don't feel pain as intensely as white Americans. And that thought is so pervasive within our culture that it made its way into a medical college, okay, a medical school. Lastly, and before I have one more slide here. Lastly, until this year, 2021, there was no dermatology textbook specifically for non-white people. And my wife Lauren and I were talking about this. The book is called Mind the Gap. So if you're an EMS educator, there's a dermatology book that shows things like urticaria and hives on non-white skin, so that you can maybe show your students what it looks like on not the person that was available for the photo that day. It took until now to do that. And at first I thought, well, that makes sense because, like I'm very pale and it would be easy to see a rash on my face. But that's just it, isn't it? It would be so easy to see it on me that that I don't need further education on me. I need to see what a person of color looks like with urticaria, because that's not something I've ever seen before. And that's crazy to think that it's 2021. Medicine has been around formally since, really in the United States, the mid 1920s is kind of this formal education process. And we're just now getting to having a book of non-white skin issues. And then last one, I promise, this is from Lois James, who's a sociologist. She studied 95 police officers in Chicago. And for skin tone bias, the same bias that I'm going to talk about here. And she found that if she called him at 2 in the morning, at 3 in the morning, and said, wake up, you have to take this implicit bias test right now, you got to go, you got to go, you got to go, and really stressed them out, the biases actually got worse. The skin tone biases got worse because we were acting, those participants were acting with a different part of their brain, right? And so when you extrapolate that idea into EMS workers, you would think that even in critical incidents, we don't release our biases. And so that's why we said we should study this. So I'm going to pause for just a moment, and I saw one question that Dave answered. Is there anything else I can do to assist anyone?
Alex, I just wanted to make a comment that, one of the things that we do, and maybe Dave, you can comment on this. One of the things that we do a lot to researchers is we say, look at the research in the last 10 years, because that's sort of the most significant. That's the stuff you should look at in your literature search when you're doing your research. And the problem is it actually ignores some of the seminal research that's done and in this area. I think it's worthwhile to go back and revisit things like the 1939 Clark doll experiment, where we're talking toddlers. So in your paper you talk about implicit bias coming in school age children. There's research that shows we're talking much younger than that, and this is the experiment that showed that young Black children would select a white doll as the nice doll, the pretty doll, and the Black doll as the bad doll and the ugly doll. And that was it's actually very emotional to watch it. If you ever watch the video, the 1939 Clark doll experiment, if people haven't looked that up. The other one was in 1968, following the assassination of Dr. Martin Luther King, was the brown-eyed, blue-eyed anti-racism experiment by Jane Elliott. So these are things that are very key that I think, people will, again, if we keep this mindset in research that we only look at things in the last 10 years, we ignore something that is very important and relevant that happened longer ago.
And even in the language, I was laughing, and I'm sure you did this on purpose, Alex. But when you say the word white knight, this concept that white is good, black is bad. I love the way in your paper you mentioned this kind of re-exposure we have in EMS to, because of social determinants of health, because of the populations we serve, we often are exposed to people who are in poor states of health in a particular type of demographic. And so it reinforces these stereotypes, which in your paper, I love the fact that you've well referenced all of this really shaping early in childhood. Like you mentioned, driving into a neighborhood and your mom saying, lock the doors. How much of that is preconditioned prior to even being socially conscious? And you're watching sort of the cycle of, if you want, the domestic abuse cycle of we don't know any different, so we just kind of keep repeating a cycle we know is evil and bad. So I'm really glad that you studied this, and I just admire the passion. We need more of this, and I think for those, the comment on the chat was, where can we see the paper? And it's been hard to get it published, which for all budding researchers on this podcast, you know that this is true. That's the hardest part, to get to the finish line, and lots of different options, and kind of can get lost in where would be the best place to get it done. But that tenacity, that grit, that perseverance, in particular on a topic that is difficult to discuss, and people will tend to go, ooh, I don't think I want to publish anything related to that. I might get into a conversation that's a difficult conversation. So I applaud you personally for that grit, for continuing on no matter what, to get it through. And it sets up that context about the importance of research and the importance of that grit in research. So great that you're doing this. Thank you. Really appreciate it.
All right. I didn't
As Dave usually gave a brief comment there, mine is more based on just the question is, I can't remember if you differentiate, where is the role of poverty in all of this? Because, poverty can cross all cultural, all
Absolutely.
no matter where you're from, poverty can be an issue. So that's got to be part of all of this too with people.
Yeah,
And
and
disability too.
yeah, unfortunately, so there's no implicit association test for disability, but there is one for socioeconomic status. And overwhelmingly, people who are below the poverty line tend to associate positive feelings with people who have high median household incomes. In fact, the biggest line was in car accidents. So in car accidents, people were shown a picture of like a Mercedes Benz hitting a Ford Taurus, and people always said, well, the person in the Mercedes must have been driving safer. So I just saw a question. Is it okay if we handle Dave Nitch's question now?
Sure. You were mentioned that there's no test for that. The Harvard implicit bias test that you can take online, and maybe we can put that link in the chat at some point. We'll try and find it and put it in the chat for folks. You can play with that forever. You can take many of them, and there's one even for patient size for obesity versus non-obesity. I mean, there's quite a few different ones. There's gender, there's ethnicity versus skin tones versus race. There's two different ones, so which is different. So there are several layers, and it's worthwhile. It's quite. I was quite surprised at some of the results that I've gotten too, and yet, in hindsight, not so surprised. If anything, it makes you more aware, and awareness is always good. So, especially as an educator, I think too.
So, yeah, absolutely. And just taking one of the tests actually is a positive predictor value for having a better worldview following the test, right? And for future scores being a little more evened out. So Dave Nitch asked, how in our research did we account for correlation versus causation? And Dave, I'm going to show you, this was the qualitative part of this study, and I'm going to show you kind of the quantitative part here in just a minute. But the truth is, the biggest challenge with doing race research, social determinant of health research, is that all we really know is that the way that we feel subconsciously slowly seeps into how we feel consciously, right? And it's the biggest challenge that I had in getting this research funded, and I'm very thankful for the Menard Center for the study of institutions and individuals at the University of Wisconsin for funding this, is that it's very difficult to say this is the only thing that causes that, right? But what we do know, and what does show very clearly in the American healthcare system, is that minorities, non-white Americans had lower qualities of health that they always have as long as we've collected that data. And so is it just implicit bias? No, probably not. Is it just that most studies in medicine are performed on Caucasian Americans? No, probably not. Is it that most medications regarding women's health are tested on men and the side effects are listed as men taking that medication? No, probably not. But all of those things create the structure in which the sandcastle lies. And if we don't try poking and prodding at each one of them, I'm not entirely sure that we'll ever get there. So, and then one more question here. And this is from Saj. I hope that I said that correctly, and I'm sorry if I didn't.
It's Sahej, and actually, Sahej is a champion of equity out here. So this is a really important question. Go ahead.
Yeah, so Sahej says, what are your thoughts on the notion that bias is a part of the human condition? So we should destigmatize the term to allow people to talk about it and ensure they don't act on their biases. The answer is a resounding yes. We should destigmatize bias. I love giving this information out because when I talk about it, at the end, people are always like, wow, so it's not just me. In fact, when a lot of my friends participated in this research because it was an anonymous survey that I did. It was an anonymous web link, so I have no idea, but I know that they took it because they called and said, "Hey, Alex, I got this result that said I have a strong automatic preference for light-skinned people over dark-skinned people. Does that mean I'm a racist?" No, it doesn't. What it means is that the way that you've interacted with the world much of your life has changed how you view society, and that's okay. And it's okay to have biases. I admittedly have very strong biases when it comes to things like socioeconomic status, right? Not saying that I think we should, burn down mansions or anything like that, but the way that we interact with the world is different. I came from being on welfare. I tend to not believe in bootstrapism for that reason, right? That you can't just pull yourself up by your shoes and get someplace, that the social safety net's what matters. So I do think that bias should be destigmatized. And I think that people should be comfortable saying like, hey, that's my bias. So that was
And
a
I
great
think
question.
you did a great job of saying in the paper, you talk about that concept of diversifying the workforce. And I really appreciate the mention of Freedom House. I really appreciate how you are sort of seeing perhaps the concept that if we associate more with people who are of a diverse thought, perhaps gender, sex, or ethnicity, that we will be exposed and less likely to consider that to be stereotypically anonymous. Stereotypically anonymous, that was terrible. So, but anomalous. That we find that if we can relate to people who are different because we know them, then it becomes less of a stigmatization of the whole kind of culture and more about, for example, Shane Henderson is on this podcast and love it because he was one of the first to bring research to us about half dose of dextrose, and knowing him makes me think differently about researchers, whether it's his gender, skin color, it doesn't matter. I get to know him personally, and that to me is important because we keep sensitizing or trying to infuse cultural humility and teach cultural humility, but it really might not go away if we keep being exposed to the same stimulus, which is when I see people who are poor, they're in poor health because I'm a paramedic and that's the thing that I see. And so I tie these two things together subconsciously. So hard to, it's I think, you can't separate those things until you meet someone who is poor, who perhaps doesn't have the opportunities you had, but they're incredibly smart, and suddenly they are contributing and improving not only their culture, but your work. They're enhancing your life because you're learning from them.
Absolutely. That's a great comment, Dave. Thank you. Dave Nitch has a follow-up question. And Dave, I'm going to answer this one, and then I want to get into the data here. So just the question is, given the high degree of controversy with the IAT generally, why did we choose to utilize that test? Great question. Okay. So the question is a little bit multifaceted. So one, why did we pick this test? Because it's the best one, so to speak. It's got over 1 million responses already. They publish their data for free, and it's the only one that's been statistically validated by a third party. Excuse me. So I like, for instance, I really love medical research, except for when medical research is funded by the people that make the drug or make the device, right? And the project Implicit Association Test has been independently validated, okay? And then the other reason is why it is that we wanted to do implicit association is that there's really no good, like, am I a racist test? And that's not what we're trying to prove. And I want to be very clear on that, is that we're not trying to make people out to be racists or even to be biased. What we're really trying to do is find a way to quantify it, right? So the reason that the implicit association test is so controversial is because it tells people things about themselves that they don't necessarily like. Okay, it's the same thing like going home to Thanksgiving for your parents and your mom says, hey, I think you put on 5 to 10, which is true, it's totally true. But you don't want to be like, God, get lost, mom, right? So you have to just kind of take it, and the implicit association test tells you something about yourself that maybe you aren't the most comfortable with. Megan, do we want to let Sahej jump in now, or should I have just a few more slides to cover the data?
Yeah, let's look at the data first, because I think with Sahej, I think there's some important points to make in the implications of the study, if you don't mind.
Absolutely, yeah, absolutely. It's my first day, so let's try and I'll follow your guide. Okay, so let's talk just a little bit about our study. We sent out an email to the public email of all certified EMTs, advanced EMTs, and paramedics in the states of Minnesota and Wisconsin. We very intentionally skipped emergency medical responders for a couple of reasons. One, there's plenty of research on law enforcement interaction, and two, despite having worked on this study for 3 years, we didn't make the survey live until just a couple of days after the George Floyd death in police custody here in Minneapolis, and we ended it the day before the Kenosha incident. So we very intentionally kind of gave a break and just looked at people who identified it, were certified as EMTs, AEMTs, and paramedics. Both state EMS boards provided us those mailing lists. So thank you to Dave Rogers at the Minnesota EMSRB and Jonathan Lockhart, the former chief of the Wisconsin Division of Health Services EMS, for providing those to us as a FOIA request, and we really appreciate that. Everybody got the same email. The email was identical. It was very generic and plain, that said, we'd like you to take this research. If you're interested, please click here to learn more. And then everybody got a random 6-digit ID that they were notified of. So if Dave took it, I'm not saying that Dave did, but if Dave took it and his ID was 12345, he could call us and say, I was 12345, I don't want my results posted. And 3 people did take us up on that, and good for them for feeling like they could reach out to us. We invited 22,942 people. 401 emails were not valid, which just given that March 31st is recertification time, make sure your email is valid to get your new EMSRB or NREMT card. Only 2,314 people opened the email. So when you really look at it, 2,314 people were eligible for the survey because they opened the email and clicked on the link to learn more information. And then 1,449 people completed the entirety of the survey and had a valid result. Okay. So you look at that, and it's 6.3% of the 22,942 invited. And that's probably the biggest heartbreaker of this whole thing, is that we ultimately stopped early due to getting a number of death threats from a number of different EMS providers in Minnesota and Wisconsin, and ultimately said, hey, this is not working for our mental health, and I think we need to stop. But the number of people that actually learned entirely about the survey, almost all of them completed it. So that's really good. And to date, this is the largest ever study of implicit association in healthcare workers. And it's not even close. The next closest one was 100. So you can see here that just about half of our respondents either worked for fire-based EMS services, or just about half worked for hospital-based EMS services. Wisconsin is very fire EMS heavy. Minnesota is very hospital-based EMS heavy. There's some respondents from rural metro and the like here, and then some public third service providers as well. One thing for us, though, is that we were a little bit overrepresented in terms of education level. So you can see here that some college includes paramedic certificate. That's a third of our respondents. Another third of our respondents had an associate's degree, and then another third approximately had a bachelor's degree. And then 187 people had a graduate degree, which is terrific. I got 3 different people who had PhDs. So three different people that had PhDs I thought was terrific and really cool, especially here in the Twin Cities, and a very small respondent of people that were high school only, and a majority of those were career EMTs and not new providers right out of like an OEC program. So which was surprising to me. I didn't expect that. In terms of race, 92.6% of our respondents were white and 1.38% were African American or Black, and it very specifically said that. It gave you the option. And then for ethnicity, not race, ethnicity, 3.10% of respondents identified as Hispanic. Minnesota and Wisconsin are both relatively homogeneous states. But we were able to get responses from just about every county in the state of Minnesota, except for counties where there are no licensed ambulance services. So for instance, in the northwest corner of the state, there's an ambulance service in Norman County, Minnesota, which is where that number 10 is, that covers all the way up almost to the border. So that's why, and then International Falls here was low as well. But Wisconsin, way to go, Wisconsin, in giving a lot of data out to us. 119 Milwaukee Fire Department respondents based on what they disclosed to us, not based on us asking if they worked for MFD or not. 60 respondents from the Milwaukee suburbs, and then just a ton of folks, 122 from the Madison area. And this study wouldn't have been as well powered as it was without them. So thank you to my alma mater state, the good state of Wisconsin. Our mean score of implicit association was 0.4715. So what that means is that any number greater than 0.0 indicates a automatic preference for light-skinned people over dark-skinned people, the positive number. And that number can go as high as 2. Anything higher than 0.15 is a slight automatic preference for light-skinned people. Anything higher than 0.35 is a moderate automatic preference. Anything higher than 0.65 is a strong automatic preference for light-skinned people. And if you reverse those numbers in negative, it's negative 0.15 or greater or less, actually, is a slight automatic preference for dark-skinned people. 0.35 negative is moderate, and 0.65 is strong. Okay, our standard deviation was very high at 0.401, and our p-value in a two-tailed t-test was less than 5/10 of a percent, which means that we could reject our null hypothesis. Our null hypothesis in this case was that there's no implicit bias that's demonstratable in EMS workers, and your null hypothesis is just the thing that you don't think is true anyway, and that's kind of what we're going off of. What was really shocking to me, though, is this is called a weighted Pareto chart. If you're not familiar, I like charts. That the most respondents, the plurality of respondents in this test, and a third of our test statistic had a strong automatic preference for light-skinned people over dark-skinned people. And by the time you got to neutral, so just before you got to the neutral bar, 90% of the respondents were accounted for. And that means that 90% of our respondents had a slight, moderate, or strong automatic preference for light-skinned people over dark-skinned people. You're probably asking yourself, Alex, is the graph kurtotic? And I would tell you, yes, the graph is kurtotic, and has pretty nice shape. There's a little bit of a tail towards the negative, but you can see here that we actually had a relatively normal distribution. And so in my mind, that means that we probably had a pretty good test sample. And so we'll continue going here. And this is our comparative statistics. So we thought, well, wait a minute, Alex, you said that your null hypothesis was that there was no implicit bias, which is totally not the case, because everybody has their biases, right? So we said, okay, well, let's compare it to all publicly available responses in 2018, which is 172,902 responses. Much better than 1,500, but certainly a statistically valid comparative, okay? And EMS providers were approximately double the mean D-score. They were approximately almost double the median score. Our range was a little tighter, which makes sense because we had a smaller group of people. But you can see Two, that our lowest score of negative 1.012, which is just barely a strong automatic preference for dark-skinned people over light-skinned people, was almost half of the lowest score of the population. And our highest score was much closer to the highest score of the populace. And this is what their data looks like, okay? This is what their responses to the IAT look like, very normally distributed. This is eye candy for people that like normal distribution graphs like me, and probably just me. So if you're asking yourself, Alex, does anybody have bias? Or if everybody has bias, why even do this? There's twice as much bias within EMS workers as there is in the general public, and that's very, very high. Okay, this is a picture of me as a much younger person. I'm going to stop sharing. My contact information can be made available in the chat if anybody would like to email me at my Gmail account. But that, in a nutshell, is our study. I keep saying in a nutshell, and I imagine just sitting in a nutshell. So anyway.
Thank you, Alex, for presenting that. Do we have Sahej on as well?
Yeah, Sahej can unmute himself, and I'm anxious to hear what he has to say. But again, congratulations. It's a hard study to do. All of us were living through George Floyd, Breonna Taylor. I also put in the chat the structural racism paper that AHA put together that specifically mentioned those individuals, and it's hard work. Have you received feedback from this study, just from people who took it, positive or concerning? Did you get some? Why are you doing this? Why are you even highlighting this?
Well, so like I said, we stopped early because we got a handful of death threats from EMS providers in Minnesota and Wisconsin, including very pointed ones about myself and Dr. Larson, who was my faculty advisor, who is perhaps the nicest human being on the face of the planet. Sorry, Dave, you've been usurped. We even got a program director for an EMS college here in the two states that we studied that asked us to discontinue our research because it was not beneficial and that there's no such thing as implicit bias. And that really took a lot of wind out of my sails, if I'm being honest. I wish I could say that it was a good experience, but it wasn't. I will say a couple of positives is that the EMS chief for the city of Milwaukee Fire Department has asked me to come out and share the results of the study just with his department, and we'll be doing that. And that the Century College, which is here in the Twin Cities in the northeast metro of Minneapolis and St. Paul, is now requiring 2 implicit association tests taken by every provider that goes to their program. And so good for them just to have those discussions.
I have to say, Dave, I find, and I don't want to sound naive or anything, but the word bias should not be unfamiliar to a researcher. This is a science, discussion, and bias is something we talk about all the time that you have to check on as a researcher. I understand that no one wants to be called a racist, a sexist, and anything-ist, right? So that's where it is. That's where. Let's plant it firmly there, and let's not ignore we're 4 white people talking about race. It would be nice to have a nice diverse panel and a good honest discussion without this kind of the attitude that you're talking about, Alex. I seriously don't really understand it. Nobody likes to be called that their care is different or could potentially be, which is not what you're studying, by the way. You did not take it to, by the way, this means that you're a bad practitioner. What we're saying is we want you to be aware of biases, or perhaps, and this is one way of measuring. And to the point about why use this test versus others if it's controversial, same reason we use Cincinnati Pre-Hospital Stroke Scale and GCS and everything else that we use, right? We have what we have, and we have the evidence for the evidence, and we try to improve upon it. So
yeah. Malcolm Gladwell did a piece on the IAT and mentions it in his book Blink, and I think it's a great we talk about intuition and as reason at high speed. We talk about all of the gut feelings that help us in EMS predict that somebody's going to really actually be sick, and Gladwell talks about the betrayal of some of that. And so I don't think it's throw out the baby with the bathwater. I think we need to have those associations be important. When I smell the burnt skin of somebody who's been in a fire, there's a lot of things that are going through my mind that are associations that might be very helpful to that patient. If I'm being honest, you know, that feeling of I'm going into a neighborhood where we go to a lot of shootings, that makes me think, okay, I'm gonna, you know, be more, well, and then there's Bill too.
I had to do that to you, Dave. I'm sorry.
Yeah,
So,
because Bill is associated with every possible laughter I've got.
so one of the things Ken Mill, who does the Skeptic's Guide to Emergency Medicine, he says the science is solid. It's the scientist that is biased. And that's something we need to think always about, is that, you know, science is what it is. It can be very precise, but what we bring into it is the fact that we are human and inherently flawed with all of this. And I try not to take anything, you know, when it comes to my biases that I have personally, they are who I am, but I like the fact that I'm aware of it. That to me is where the value really comes in and stuff. And that's why, as he always says, Ken Mill and his thing is, you should be skeptical. Yeah. It's good to have a healthy degree of skepticism and ask questions and look for that clarification. And I love the work that you've done here. This is great, but we need more like this. We need to ferret this out now more. We need to tease this out more so we can help our providers of the future be better than what they are currently right now with awareness.
I love it. I love it. Just the awareness of the fact that, for example, patients get less pain medications. I'm just trying to get Sahej to speak up, because once you're aware of the bias, then you can address it. You can, you know, that's the humility part.
If you're wondering, if anybody's wondering, there's two thoughts I just want to address after this. But if anybody's wondering, the adjusted odds ratio for African American children to receive pain medicine for a confirmed fracture is 1/5. So for every 5 white children that receive pain medication for a confirmed long bone fracture in a pediatric emergency department, 1 African American child receives pain management, which kind of rounds me out to my next point. So David Nitsch, back with us, says, appreciates my answer. Thank you. I've been practicing. You said it's a challenge to agree that controversy is caused by seeing things we don't like. There's a large body of research that calls the validity of the IAT into question. So let's address the elephant in the room. There have been 1 million responses to the implicit association test. It's been statistically validated by a third-party body, and it is the gold standard for implicit association. There are 3,500 peer-review published articles that reference the implicit association test as the body of their work, and there are 5 articles that question the validity of the implicit association test, and one of them is on vox.com, VOX. So yeah, absolutely. Is there a question about it? Yes. There are more statistically validated studies regarding the implicit association test than there are about the Cincinnati pre-hospital stroke scale, and nobody blinks an eye about it. So I agree with you, David. It's controversial and it's good, but we have to get past it's controversial to say that it's a problem.
Can we bring in Sahej too? I'd like to bring in Sahej because he is one of the authors of the paper on cultural humility and EMS education, and that's what we are as an education research podcast. So Sahej, are you unmuted?
I think so. Can you hear me?
Yeah. You made a really important point earlier about the evidence that we were talking about earlier. There's quite a body of evidence about working or about the independent association of race with, poorer outcomes or fewer, pain meds or other things. That's independent of things like that are controlled for socioeconomic status and insured status and educational level and those kind of things.
Yeah, absolutely. So there's been some researchers who've tried to tease out the correlation versus causation piece, right? Maybe it's socioeconomic status, maybe it's education, maybe it's insured status and it's not race or ethnicity. And what they found was that when they controlled for all of those things that could be confounding variables that could muddy up the data. They found that minority or minoritized patients still received worse care. And you mentioned a few minutes ago that this research, which by the way is amazing and excellent, and we need a whole lot more of it, and I'm very grateful that you did it, it didn't look at how it impacted patient care. Well, Dr. Bill Lord and I did do that, and some others have done the same thing with pain management in EMS specifically. And what we found is that African American patients in a massive population that our data was pulled from of 59,915 people, if memory serves, were 40% less likely to receive pain meds when they were in pain than similarly situated white patients. So I understand this is an uncomfortable conversation, but that I think is what makes it important and critical. And it's also really, really, really hard to argue with the data that shows that we've got a lot of work to do. And then just very quickly, we did a preliminary research here in New Mexico. And by the way, I can't turn on my camera. I'm not sure if it's the settings that this is set up in or my lack of knowledge. But in New Mexico, where we are a state that is majority minority, we're 47% Hispanic population and about 10% Native American. We did a study that's only at abstract right now, but we looked at whether or not Hispanic patients, minority patients, are treated worse with regard to pain in New Mexico. Our EMS provider population is 37.4% Hispanic. We actually have to report race and ethnicity every time we renew, so we know that. And what we found is that that gap that exists throughout most of the rest of the United States is closed in New Mexico, where we have a majority minority population and also significantly greater percentage of Hispanic providers and Native American providers actually in our workforce. So there's evidence, not just from us, but from other folks, that just working in a more diverse environment provides protection for diverse patients who you subsequently see. One of them was about fetal mortality, neonate mortality for African American patients. If the provider caring for them had previously worked with African American nurses or doctors or whatever, they were less likely to have those babies and mothers die after birth. So evidence is incredibly strong.
I think that's very powerful.
Yeah, and where we go from is as I think where people are get spun up, and that's this whole idea that, well, wait a minute, somebody might take my job because you need to have X number of people or whatever. Where we go from is I do think that that's one of the areas that makes it quote unquote controversial, even though I really don't like that word. I don't understand why this is controversial versus anything else that we talk about, intubation and other things. So but we talk about a couple of words I think that have been brought up on this podcast that I think need to be expanded on are equity-mindedness, not just
right? Yeah.
Equity-mindedness, meaning that individual students, let's talk about students because we're educators, need to get what they need in order to succeed, right? Not everybody gets the same thing. It's more about individual need. And then the other when we talk about equity and inclusion. And when we talk about, I think in your paper, Alex, you talk about diversifying, the workforce. But you can, that's why I like equity and cultural humility. Cultural humility is the other principle, rather than this competency. It used to be cultural competency, which suggests you can have a check sheet to say, oh, check box. Guess what? You're competent now. And that's just not. We've moved away from that. We're moving more toward an idea of having a perception that students, patients, all come from different, perceptions that they, and we respect that, and they are autonomous, and they can, interpret the way that their medical treatment based upon what your information you're giving them. Those are great concepts, and they go independent of this kind of bean counting that you can land on and say, okay, if I just have X number of women and X number of this, hey, I could be a sexist too. I'm a woman and you could select me.
Well,
Is that the person you want?
And Megan, that's actually in Alex's paper, one of the really striking pieces that hit me hard was that while the fire department in Los Angeles has gotten to 51% non-Caucasian, it's still 3% female. And so we have an entire world of equity and inclusiveness that's just, you know, dichotomously split, for example. Just you know, thinking about not diversity as just skin tone, but also all of the pieces of what makes you you. And because we're ending here, I also want to say that this is not a yes, no, it just happens. And then we've checked the competency box or the diversity box or the equity box. I love the part, Alex, where you wrote about the lack of sleep and that it affects how we perceive. And so officers with lack of sleep had a larger bias. And I think, you know, when I think of when I'm tired and I don't want to really actually do my job as well as I want to when I have energy, I think, gosh, maybe that's that. To me, that signals I'm less likely to, whether it's give pain medications or trust that somebody's actually in pain, because I'm not watching my internal, you know, barometers. My measurements are off.
Yeah.
I'm guessing that Bill's hair is
Alex,
indicating that it's time to be done.
I want to thank you for your paper and the work that you've done in your presentation today. I appreciated it greatly, and thank you for helping move us along. I look forward to future work that you're going to do, as well as other people to even mimic your work. So again, thank you. This is a wonderful discussion, and we need to have more like this.
Thanks, Dr. Chu.
Bye.
Thank you so much, Alex. If you have any final comments to make, we're going to go ahead and end. Did you have anything? We hope to hear from you more and have you participate more and talk about equity and cultural humility and other things that, you know, weave those in through our discussions of other educational aspects like pedagogy and things like that.
Absolutely. I'd love to come back if you'll have me. And if anybody has any questions about the research, there were a couple that I wasn't able to get to about like our specific study methods and things like that. My email is alex.trembley, Trembley @gmail.com. Please don't use it to sign up for any spam though, okay? But email me with questions. Thank you.
Great, thank you. We look forward to seeing you all again, and we'll continue our great discussions about education and education research, and maybe you've seen something out there that you would like to discuss. Thank you all for joining us. We will be back on April 23rd, 10 a.m. Pacific, noon Central, but we'll be back before then for the clinical podcast with Dr. Remley Crow, Dr. Tony Fernandez on Monday, April 12th. So don't forget, join us. If you want to present an upcoming article, maybe you have something, or if you just have a good one that you'd like to send us, email David Page at dpage@emsed.net. Thank you all.